So this is my disclosure. So I will give you maybe the more like an introduction to what we usually do in the office setting of hysteroscopy in IVF center. And why we use the office hysteroscopy when we look at the blind procedure that we are doing, like the endometrial biopsy, and the diameter of the instrument is quite similar to the diagnostic hysteroscope. So instead of doing blind procedure, we should do with the direct visualization of what we are doing to limit the chance of getting the adhesion and all the things that can go wrong with the complication. So as a previous speakers also mentioned that we do the office hysteroscopy with the vaginoscopy technique. So there was no speculum, no tenaculum, no cervical dilatation, and minimum anesthesia. And we see and treat the lesion with the direct visualization. So and from my last year in my IVF clinic, we perform 134 hysteroscopy, and most of it I do a lot of the dysmorphic uterus. It's a congenital malformation, and the pregnancy after the surgery is quite good, about 60% without the IVF treatment further. Okay, so what can we do with the minimal resection? We need the operative hysteroscope with the 5 French instrument. It may be the bipolar needle or the semi-rigid scissor, and sometimes we use the minimum the small resectoscope. And this is the setting. So we create the relaxed environment for the patient. This is from my operating theater. So you see that it's more relaxing. Patient can see the sky, and also with the adjustment of the light to help with the visualization. And there are many indications to perform the office hysteroscopy. As you can see here, from abnormal bleeding, the polyp, the myoma, missed abortion, or even the workup for infertility, the ESHRE retained IUD, or the congenital malformation of the uterus. And there was some contraindication that we should do this in the hospital, especially when we're expecting the operative time to be longer than 30 minutes. Okay, for the polyp, the small polyp, we can just use the semi-rigid instrument with the sharp scissor and the crocodile forceps, and you just grab it, and we just push and pull to get rid of the lesion. But for the larger one, the bipolar tweezle is optimum to cut the lesion. We can cut it to make it like a small slice, and we remove it at the end, as you can see from the video here. It's just a minute, and the lesion is gone. Okay, and for the submucous myoma, according to the tissue that is more stiff, so we divide it in half and we slice into the sphere. Or if it is bigger, we can use a lot of instrument that is available right now, like ESHRE, like the resectoscope, or even the semi-rigid. In some cases, it can still be used, or with a diode laser. I use the diode laser lately, but the cutting speed is much lower than the other, so we stop using that at the moment, or the cold loop. And nowadays, from my data, there are a lot of the congenital malformation of the uterus in the infertility patient. we found it more than before. Like in Thailand, we found about 30% of the cases have the congenital malformation, and mostly it's the dysmorphic uterus and some septum. So with this, we can easily treat in the office with just the bipolar needle. For example, this the dysmorphic uterus, or in the ESHRE ESGE classification, they classify as a class U1. So this is in comparison. You see the left panel is the normal uterus, and the right panel is a dysmorphic. So the dysmorphic is the cavity is smaller and pale, and you cannot see the tube opening. So we can see and treat this condition with semi-rigid scissor or with the plasma energy needle, which is much faster. Or I use the bipolar hook with a resectoscope. Also, the diode laser can also be used in this condition as well. But from my experience, the plasma needle is quite fast and effective, also as a resectoscope. But sometimes according to the size of resectoscope, is that the diameter is about 5 to 6 millimeters. Sometimes it cannot be done easily because of the narrow of the cavity of the patient. So the bipolar needle is get the work done without much bleeding in comparison to the scissor. And this is the example of the result from the same patient before you see the narrow cavity. And this is just a month after the surgery. The cavities become normal. And reproduction after the surgery is quite well. Like from the information I told you before, that the pregnancy is about 60% within a year. And for the septum, we can do with the as the same as the dysmorphic uterus. We can use the scissor, we can use the plasma needle, and also the diode laser. Actually, man, there are a lot of people talking about it already. So, but usually in my experience, I prefer with the ESHRE, I prefer the semi-rigid scissor, just a cold knife, and gradually open the space and see where the cavity is. So in summary, there are female causes of infertility that can be treated with the hysteroscope in the office, and the minimal invasive resection in the office hysteroscope system, it makes the office hysteroscope much easier and faster, and the recovery is quite good. Okay, that would be all for my presentation.